Good evening, everyone. I welcome everyone and I invite you warmly to the 32nd Zoom session of UMANG today. I am Dr. Gauri Saroj, Critical Care Consultant at Jupiter Hospital, Thane. A few lines about UMANG. UMANG was created by like-minded medicos coming together for expanding their horizons beyond the limitations of professional learning to start a different kind of CME, creative medical evolution. In this, we have various insightful, inspiring, interactive online sessions by medicos on non-academic life skills, which are not mentioned in the textbooks, no chapters describing them. And we've had 32 sessions involving from finances, medical jousting, parenting, and so many things, emotional quotient, everything we are covering and rare topics. And we have a YouTube channel called as UMANG Empowering Medicos, which we upload the sessions later and you all can watch that. Most of the faculties range from medical students to resident doctors to senior from all different specialties. And we are here since last 3 years, since November 2020. So welcome everyone to UMANG session. And yes, today's session is end of life care. We are talking about graceful exit for the terminally ill patient. And who, as a treating doctor, doesn't want our patient, terminally ill patient, to have that freedom to choose, to go peacefully, gracefully from the terminal illness. It's really a best parting gift to from the family and the treating doctor to these kind of patients. So let's hear from the esteemed panelist how and when and how actually on the court to go about it dealing with these kind of patients. So I welcome warmly Dr. Sunil Dhaliwal, Dr. Seema Rao, and Dr. Rajam Iyer. Kindly introduce yourself quickly, and then we can move ahead with the sessions. Thank you. Yes, Dr. Sunil.
Yeah.
Yeah.
Can you hear me now?
Yes.
So this is Dr. Sunil Dhaliwal here. I'm a pain and palliative medicine consultant, currently working in various corporate hospitals. Plus, I have my own home care team wherein we cater patients across Mumbai, Navi Mumbai, and Thane district. And it's not only for palliative care; it's for integrated oncology. So right from the diagnosis till the end of life care, we manage whole spectrum, both in hospital setup as well as home setup. So I'm in this field since last 14 plus years. 6.5 years I was in Tata Memorial Hospital, and from last 7.5 years I'm doing it in a private sector. So hope today's session will be much more conversational, much more interesting, and let us learn together. Thank you.
Yes, Dr. Rajam.
So I'm a pulmonologist trained from Bombay, and only since the past 7 years, due to a personal bereavement, I have trained myself into palliative care. Compared to Seema and Sunil, I'm very junior in this field, but my focus is non-cancer palliative since my basic training is in pulmonology. I'm attached to Bhatia and Hinduja Hospital.
Got it.
Great.
Thank you, Dr. Rajam. Yes, Dr. Seema.
I'm Dr. Seema Rao. I'm a psychiatrist and now a palliative care physician. I've been in this field for the last almost, I think now 12 plus years in palliative care. Like I told you before, I worked for about 7 years at Tata Memorial Hospital and then for 2 years at Kasturba Medical College, Manipal. Now I am heading the research, education and training of a hospice. It's a 73-bedded hospice in Bangalore. It's called Karunashraya. So I work there and also provide quality improvement, clinical support, all these activities. It's a pleasure to be here today. Thanks.
Great. Welcome you all.
Thank you.
So today's session, basically, we wanted to have this session with the intent that our own medicals, our own colleagues, our own paramedical professionals, nursing care, everybody should be primed about how to, first of all, communicate with patients who are struggling the relatives who are struggling, and little more empathetic towards whole thing. So we wanted to highlight the spiritual aspect also in caring these patients, and we thought the best panelists should be come for this forum, and all three of you are great people. So we'll start with the questions. We have put very simple questions so that our audience who is attending gets the brief idea. I think this may be the first session which will be having a continuous sessions, because all only in 1 hour we won't be able to complete the entire discussion. It's a very vast topic. So Dr. Sunil, can you briefly tell us what exactly is palliative care, and what is it different from the routine or clinical practice, routine medical care? Dr. Sunil, you're muted.
Yeah. So yes, there are differences. So when you talk about palliative care, it's a specialized medical care which is primarily focusing on relieving the symptoms, the pain, the stress of the serious illness. So it differs from other types of medical care such as curative care management, because we prioritize more of quality of life and addressing the physical and emotional support, spiritual needs of the patient. So unlike curative care management, so palliative care aims to provide treatment alongside curative care so that both the things go runs parallelly, and one who is more focused towards disease directed, there should be someone who is more focused towards suffering part. So if your suffering is on a lower side, your fighting ability indirectly is on a higher side, and when you're fighting well, the treatment taking ability is on a higher side. So palliative care and curative care goes hand in hand.
Yeah, thank you, Dr. Sunil, for that. This is for Dr. Seema. Is the palliative care the same as end of life care? There's a lot of confusion. What is palliative? Is it same? Why two different names? So is it the same or different, Dr. Seema?
So I think that is one of the basic confusion that comes in, when you say palliative care, people think, okay, it's for only meant for terminal patients, right? People who are dying, only they get referred to palliative care. So though initially the concept started like this, the concept of palliative care has evolved over the decades, right? Now, they are interrelated, but they are not synonymous, right? So palliative care, the current definition says it can begin at any point in the illness trajectory. It begins at the diagnosis, at the point the patient gets diagnosed. If there is a serious health-related suffering, you refer them for palliative care for the alleviation of the suffering, right? So it is not dependent on the stage of the disease. Even patients who are under curative management are eligible for palliative care. When we talk about end of life care, that is when we start when a disease becomes incurable. So from that point onwards, end of life care starts. Ideally, generally in UK, or when we talk about the definitions from US, it says in the last 6 to 12 months of the patient's life. That is when end of life care starts. And here, the focus is primarily on symptom management. So you have the curative options you have exhausted. So the disease management starts becoming smaller, and symptom management, psychosocial support, spiritual care, caregiver empowerment, these aspects start gaining more importance. So palliative care begins from the diagnosis of a disease, can run alongside curative treatment. Whereas end of life care begins from the point when a disease becomes incurable and during the last 6 to 12 months of a patient's life. So I think that distinction we need to understand. So the earlier you refer a patient for palliative care, the lesser or more holistic the care becomes.
Thank you. So Dr. Rajam, since you're managing non-cancer patients, what have you observed that how does the palliative care help in the patients to improve their quality of life?
So as Seema just said that, the whole concept of palliative care is to address health-related suffering. And you and me, being professional caregivers, have seen patients go through chronic serious illnesses or even acute illnesses. The main point that we forget in our training as doctors is that we do not budget suffering. And that is the whole point that we identify in palliative care, because it's not just about giving prescriptions and medications, but it's a whole lot of other situations that both the patients and the caregivers go through. For example, physical symptoms for the patient, emotional, psychological, financial, social, spiritual problems that as a family, the whole unit goes through, especially if it's a chronic condition like, say, COPD, interstitial lung, dementia, Parkinson's, motor neuron, CKD. So again, there's another myth we would like to bust here, is that palliative care is not just for cancer patients. Palliative care is for any kind of illness, like Seema mentioned, even if a patient is going to be cured of his tuberculosis. But during that time, if he's going to struggle, if he's not going to cope, it's for people who are not able to cope. It is not diagnosis based or prognosis based. It is a need based science, art, and craft. And that's why it really focuses on the quality of life. See, quantity of life, as doctors, you and me can't guarantee for our patients. But the least we can do is to see to it that we make the patient comfortable in the given circumstances. And comfortable is not just physical, it's the whole attitude. How can he be made more comfortable to walk, talk, eat, breathe, but also to think safe, also to enjoy whatever life is left for him if he's suffering an incurable serious illness. So the focus is on quality of life, and the focus is a holistic approach. And that's the beauty and ethos of palliative care.
So basically, all patients who have a chronic illnesses should be referred.
120%, because you as a primary consultant can focus on the illness, can focus on the COPD, can focus on the cancer, can focus on ABC. We as palliative care team with a doctor, nurse, social worker, volunteer, physio, psychologist, counselor can do the other hand holding. Are you worried? Are you not sleeping? What is bothering you? Are you scared of something? What is your anxiety? The daughter can be worried about the father. The family as a unit can be handheld during this journey. So the specialist can focus on what they are trained for, and we make that journey bearable. So, it's not that we can change the outcome in many of our patients, but at least we make the journey more friendly, bearable. And like I always mention, death is one thing that is a surety for every one of us. But a bad death is avoidable. And that is the whole concept of integrating palliative care in all specialties, so that we discuss these sticky issues. See, you and me both will agree, like you said, during our training, there is no concept of making people learn to talk. And talking of death and dying is another level. We ourselves are not comfortable talking to patients saying, come on, let's talk about your death. It doesn't happen, and it cannot happen that easily. It is a very difficult topic. So the earlier you talk about all this, especially in a chronic serious illness, the patient is already thinking about death. We need to see to it that we put his goals of care in place so that he gets what he desires, and we are able to offer him the dignity, comfort, and respect every human being deserves.
Yeah, and I love this, like when we are treating, we are so mentally exhausted, especially as a critical care physician. It's emotionally draining for me to handle their emotions. And then the treatment part remains behind. If somebody is there who is taking care of this, is definitely helpful. Yeah, thank you so much.
So that's what we say, no? There is a main actor, there is a supporting actor, right? Some of the times we bring the analogy of the Diwar movie, right? Amitabh Bachchan was there and Shashi Kapoor was there. One is the main, the other had the supporting role, right? So when a patient is dealing with a chronic illness, right? Treating it, managing the illness is the main role. But there are the ramifications of the illness, which is vast, and the doctor may not be able to handle the complete gamut of the disabilities and distress that the chronic illness brings in. And that is where the supporting actors come in. So it's a
True.
synergistic, approach that you have, and finally, the patient benefits at the end of it.
Yeah, and the doctors too. Yes.
It's a win-win for everybody. I know when my family members fall ill, I'm a complete wreck. I can't think straight. I'm worried. And how is it different for our patients? They are in the same situation. It's worse for them because they're not even contacts with doctors. They have to wait for appointments. They have to wait in casualty and they know nothing. So I feel if I went through what I went through with my father, and I know how emotionally challenged I was, I couldn't make decisions. And the same thing with non-medicos. And what can they do? They will just rush to casualty. And then it's a conveyor belt. Somebody needs to sit down and tell them
Yeah.
that this is not going to work, this is going to work. And that cannot be the treating specialist, right? It has to be somebody else who has the time, bandwidth, and the training. And it has to be a multidisciplinary team. एक आदमी से नहीं होगा. And it's difficult for you to be the doctor, the ICU person, the one who puts the lines, the one who makes the decision, and to sit and talk. So it's very difficult.
Yeah.
Even
And
for
for
all.
the, as for the medicals, it's okay to take supports from subordinates. That's important. Yeah, Dr. Sunil, this one is for you. What are some common misconceptions about palliative care and how can they be addressed?
The first one is same. Palliative care is end of life. So most of the people, even from medical background, they believe that palliative care is only for the patients who are in final stages of their life. So for them, already we have answered. It's not about final stage. It's about any stage and any age. So these two are important factors. So no, I mean, you should never think about whether to refer or not to refer. The only primary first thing which comes into the mind of the medical professional is if the patient is suffering, then yes, there has to be someone who is taking care of that suffering. So when we broadly classify chronic illness, so the treatment management have two halves, treating the disease and treating the suffering part of the illness. Both the things should go hand in hand. And that's why you require an additional team who can take care of the suffering part of the illness. And that's how you improve the quality of life. In turn, there are evidences which says that because of improvement in quality of life, the quantity of life also improves. So palliative care is never at the end. It is right from the diagnosis of the life-limiting illness, and if patient is suffering, has to be mitigated. The second common myth is, if I offer palliative care, am I giving it up? Or is like, I am now, there is no hope, or, there are various phrases to it. So the answer is no. It's not when you are taking palliative care, you are stopping curative care treatment. Palliative care management and curative care management goes hand in hand. There are cases who are referred to us at the initial stage of the illness, for example, cancer, which is more been common for palliative care, wherein the pain and the other suffering, not only physical, the psychological, social issues, which we'll be talking about in our few more questions. So those aspects has been taken care of, and patient is on curative care management, and now patient is being termed as cured or cancer survivor. So palliative care, when you are opting palliative care, there is no hope. ऐसा नहीं है. You should opt for palliative care if you feel that you are suffering and the suffering is not limited to physical area. It may involve other dimensions of your care. The third important thing is palliative care is only for cancer. As Dr. Rajan rightly said, it's not only for cancer, cancer and other life-limiting conditions, primarily heart diseases, COPDs, ILDs, neurological diseases. So yes, any patients who is suffering for a longer duration, whose disease may or may not be cured, but suffering is the integral part of their journey. They have to meet or consult palliative care doctor. They'll be better, the outcome will be much better with respect to quality of life. And in last few years, my experience, one more myth is like most of the patients when they are referred to us, so they are referred to us when they do not have any money, and then the concept of palliative care is expensive has started coming in. Now it's a very gray area. I don't want to go into that form, but number one, palliative care is never expensive. It's a misconception. There are various levels where you can offer palliative care. It's not only a hospital. So hospital is one setup. Hospices are available. Palliative care centers are available. Community-based caregivers are available. Home-based care is available. So there are various places where palliative care can be opted for. When patients do not have money, or when they are done with their insurance wala thing, mediclaim wala thing, and when they do not have financial support, at that time, just pitching them to palliative care and creating a mindset that palliative care is expensive now because we don't have money. We healthcare professionals should, think about this. We are
Yes.
only ruining, yeah, we are only building up these things in their mind. So how patient or caregiver knows that palliative care is at the end? I think it started from our side. They don't know about it. So if we
Hmm.
create awareness among our healthcare professionals, then absolutely there will be no myth, I think. Because
Hmm.
I have good oncologists who refer patients to us right from the diagnosis, who comes with severe pain, bone metastatic lesions. So when the oncologist says them कि चलो ये कीमो वगैरह शुरू करेंगे, this is the protocol, meet a palliative care doctor or pain specialist, and they are happy meeting us.
Hmm.
But then there are certain group of people who refer patients saying that your treatment cannot be done because your general condition is very poor. Once you improve your condition, come back. I refer to
Hmm.
palliative
Hmm.
care. So how the
Hmm.
general condition became poor, and they say that we do have treatment, but your body is not in a position to take the treatment. So who is going to take care of the body then? This is our responsibility. If you try to put that message across that patient is dying, go to palliative care, they will think palliative care is end of life. It's we who have to take the onus first and then take the bandwagon ahead. So I think these are the myths. We can
Yeah.
definitely work on these myths by increasing awareness first among healthcare professionals, second among patients and the caregivers, third training healthcare professional to have this mindset or having the principles of palliative care into practice, and they should start breaking the ice about the benefits of referring patients for palliative care.
Yeah.
Then integrating the palliative care into the existing healthcare system, that is most important. Not every hospital or not every consultant, I have come across so many good consultants who never finish their slides without palliative care word or without palliative care thing into there.
Hmm.
But
Hmm.
most of them, they either tend to forget referring patients to palliative care, or they just tell them "Ki, we do not have any treatment." And most of the patients who opt for alternative medications or opt for other forms of treatment, when they are referred to palliative care, they are shocked कि हमने 12 साल से treatment लिया है. Nobody uttered the word about palliative care. From last 12 years, I'm taking chemo, radiation, and surgery. And one fine day they say कि अभी treatment नहीं है, बंद हो गया, आप चाहिए तो घर लेकर जाओ और आराम करो. बट वो घर कैसे लेकर जाना है,
Yes.
आराम
Yes.
कैसे करना है, ये आराम के दौरान जो तकलीफ होगी वो कौन अब ठीक करेगा? So these gaps we have to fill,
Hmm. Hmm. Hmm.
and involving community people also. So when we involve community leaders or local NGOs, or there are organizations who want to work for cancer patients. Most of the people, they are working for treating cancer patients. Now, when you go to the statistics, 80% of the cancer is diagnosed at last stage. So out of 100% patients, 80% are directly for palliative care. Then, if that is the terminology. So 20% patients bach them. Now, in that 20%, do we have 100% results for treatment? No.
Yeah, we don't have,
So
and
if
also many
we
consultants we don't have time also to discuss the
forget
details
about
about the
time,
patient.
now when we go to statistics, out of 100%, 80% is directly advanced stage cancer. 20% patients you are treating, and for these 20% patients, the result is also not 100%. So imagine, even if you have 50 or 60% of the results curing the cancer, then the group of out of 100, 90% patients directly require palliative care, and full world is concentrating on that 10% only. So
Hmm. Hmm. Hmm.
I think the balance should be there. We should know
So,
when
doctor,
to
yeah,
hold on, and we should know when to keep,
correct.
flow it.
Thank you, Dr.
So
Sunil.
yeah,
So, Dr. Rajam, in a nutshell, can you tell us a few patients which healthcare provider should identify to be referred to for palliative care, apart from cancer patients?
So,
The
like
other
I said,
conditions.
it is not diagnosis based or prognosis based, it is need based. And when
Hmm.
you, as a doctor, for example, me as a pulmonologist, 7 years ago, when I was a pulmonologist, I never told a COPD patient or an interstitial lung patient that his trajectory is going to be like this. And there will be a point that even putting him on a ventilator is going to be futile. Now, my outlook has changed because my whole idea here, what I believe is, as doctors, okay, we know the trajectory of dementia, Parkinson's, COPD, ILD. Therefore, whose responsibility is it to foresee and foretell with our patients and caregivers? It has to be ours. We cannot tell patients and caregivers, this your diagnosis is COPD. I'm writing these inhalers. See you after 3 months. The point is, you have then seen a COPD declining gradually, right? And it's like a falling off the skyscraper. We trying to talk these communications only when the patient on the first floor. Abhi kuch bhi ho sakta hai. Patient बहुत serious hai. What were you doing to all the 35 floors that he was falling? We did not take time off to have timely, sensitive, unhurried conversations. So communications, conversations is the whole hallmark of being a doctor. We need to foresee and foretell because we have gone through those books. For that patient, it's the first ILD in the house. It is the first COPD in the house. It's the first dementia. So he's going to hope for the best. So all those conditions which we as a doctor know, we need to foresee and foretell and then plant that seed in their mind that this is an incurable, this is progressive. There will be a time where things will not work. Therefore, we need to talk about it. And you have been a consultant and physician with that patient for 5 years, 6 years. You have a rapport. He's going to listen to every word you are going to say.
That's true.
If you are going to be able to pick up those patients, and therefore there are beautiful papers published both by Manipal, which is Blue Maple document, which I request all doctors to read, and also the gold standard framework, which gives you criteria for referral to palliative care in every chronic condition. So for example, in COPD, it is an elderly person with multiple ICU admissions or 24-hour oxygen or on NIV or declining lung functions or unmanaged difficult comorbidities. So there are in each Blue Maple document, if you Google search, along with Manipal or the Department of Palliative Medicine there, they have come out with this document, which is very helpful. So if you sit in front of a patient and in your mind you think, will I be surprised if this patient is not there for next Diwali? In your mind. And if you think this question results in an answer, no, I think the probability of him dying is more, that is the time to integrate palliative care. So it's a surprise question in your mind. Not all your patients will fit that criteria. But if you sit and think, will this man live for a next year? If the answer to that is no, it is time to integrate pro-palliative care, proactive palliative care. Because that is the time he has enough time to get used to you. Suddenly you're not saying, abhi main kuch nahi kar sakti hu, please go to the palliative care. That is also not right. You're transitioning him from curative to palliative so that we as palliative care physicians can transition from life to death with dignity, comfort, and peace.
Thank you. Thank you. That's a precise way of answering.
Yeah, is it available for all neurological patient also, this kind of guidance?
Yes,
It's only for COPD.
Absolutely.
for
Absolutely.
for all chronic illnesses. So the gold standards framework, it provides you 3 levels. One is the surprise question. One is the general functioning of that individual. So there are certain points which will point out to you when this patient has to be referred. And then there are disease-specific indicators. That is for any chronic disease. They have for cardiac heart failure, pulmonology, they have for oncology, then renal failure, dementia, motor neuron disease, Parkinson's, and frail elderly. So and stroke. Like, so you have for any chronic condition, it is described.
So it's
very
available where, all this thing?
available. I can share it with you. The WhatsApp group is there. I can share it with you. And so you have 3 levels. One is your surprise question, where the second is the general indicators, and third is the disease-specific indicators. If you are aware of this, it's becomes easy for you to triage in any setup, which patient needs the referral and who doesn't.
So another problem that happens, we just want to highlight it here, is very often there are doctors sensitive to palliative care. For example, certain neurologists, now the respiratory physicians I work with. But the minute you tell that to patients, the next question the patient, am I going to die? So it becomes difficult for the doctor to convince him to go and see another consultant. Also, the resistance of paying another consultant. See, in private practice, which most of our patients do, I am seeing you for 10 years. You have been treating me for COPD. Now, why are you sending me to another doctor? So, the way, therefore, some doctors try to communicate this with patients is, this doctor is a part of my team. So it's not that I'm abandoning you.
Yeah.
Two, also that she or he is going to focus on your quality of life. we'll see how to improve your symptoms. The minute you say palliative, to some patients also, they resist saying, "Aap bolne wale ho ki main marne wali hu." So, therefore, to kind of you maybe polish it a bit, they say, let's go to meet this doctor to see how we can improve your quality of life or improve your symptom control. So it convinces the person to go and meet, and then it is obviously the duty of the palliative care team to see to it that then they realize, because the time spent, the kind of discussions we do, simple things about family, asking caregivers if they are coping, because you and me both know, if you've had a elderly parent or a grandfather of COPD, ILD, it is multiple hospital admissions, multiple nights outside the ICU. Your full life is deranged. Mother cannot come on marriage because mother has to stay with somebody. A husband cannot go out because it's a complete derailment of everybody's social life and fabric. So it helps the quality of discussions once you get trained in palliative care, trained in communication skills. So it also sensitizes doctors. Please send your patients to palliative care and not just like tell them it's tata bye bye from me, only now palliative.
I
It's
think
not
the word supportive will be more applicable.
Yes.
Supportive is a common
Supportive
word
care
and
management is
is
the
a
word which
correct.
primarily most of
Yes.
the consultants use.
Yes.
comfort
Yes.
care, all of that.
Oh, huge role of the primary treating doctor here.
Yes.
Obviously.
Yes.
It's concurrent care, not either or.
Yeah.
It goes hand in hand. The two
Yes.
type of care, and it goes hand in hand.
Yeah, Dr. Seema, this one is for you. How important are psychosocial and spiritual issues in palliative and end of life care? This is very close to Pinky. You can see the smile on her face. Yeah.
So when we look at quality of life, right, there are four dimensions what we talk about, right? Physical, emotional, social, spiritual. So if you see the biological aspect, the physical aspect is just one dimension. The psychosocial spiritual, the rest three dimension parts of the dimension is psychosocial spiritual. And that is probably one of the dimensions that we are least trained to handle, right? Our whole training in medical college, when we study, is about managing the disease, but not the psychospiritual aspects of what a chronic disease can cause. One of the first things, suppose a person is diagnosed with cancer, there's going to be a lot of emotional upheaval that they go through, right? It's not only preparing for the treatment of the disease, but also the losses that they accumulate over a period of time. It's the caregiver as well as the patient undergo a lot of losses. They may not be able to go to work. There will be financial insecurity. They may not be able to fulfill the roles that give them meaning, right? If I'm a mother and I take pride in looking after my children, when I go for chemotherapy, when I come back exhausted, I may not be able to fulfill those roles. So it's a one loss after the other keeps coming when you have a chronic illness, and having to deal with it, that can cause a lot of emotional upheaval. The other question that commonly comes, what we call term it as a spiritual a question, is why did this happen to me? What wrong have I done to suffer like this, right? um, I have lived such a healthy life. I've never smoked. I've never taken alcohol. I've exercised all the time. But why did I get something like this, right? These questions, there are a lot of these questions that come in, which again contributes to that distress that this chronic disease brings. One, on at the physical level. The second is the psychosocial level. And then you have a whole community that tells you, be positive, be strong. I'm sure you can overcome this, right? But then for the person who's facing the disease, being strong and not talking about it can cause, a lot of upheaval within, correct? So it's extremely important for not only healthcare providers, but also for the caregivers, the ones who are looking after the patient, also to understand the psychosocial spiritual aspect, as we call what is happening to the patient, and how they can give adequate support to the patient too. Second, the caregivers are also going through the upheaval, whom sometimes we call as hidden patients, right? They are looking after their loved one who's having a life-threatening illness, and they see them suffer. They also undergo that suffering. They are mirror patients. They mirror the suffering of their loved ones. And does our healthcare system have any give a thought to the caregiver? राइट वी टेल देम अभी हमसे कुछ नहीं हो सकता है, आप उनको घर में लेके जाओ, घर में देखभाल करो, मगर घर में हाउ डू यू लुक आफ्टर देम? Some patients with cancer have wounds, and when I interviewed some of the caregivers for my thesis, the one of the difficult thing is they are not doctors, they have never seen such gruesome wounds, they have not seen, and they've had to do this dressing of that wound at home, right? So there are a lot of these aspects that come in when patients have chronic illnesses, which need much more support, which in a normal day-to-day medical hospitals or in a setup you may not be able to provide. And that is where the team of palliative care, with the social workers, with counselors, with volunteers, they are able to provide this what do you call it, layers of support for the patient. It's not only the physical aspect, isn't it? So that's where the team is able to build that support system in and around that patient and the family member, so that they are able to manage this difficult journey, along with them.
So, Dr. Sunil, you have been working at the community level since last couple of years. So, what are the resources available at the different levels, at the hospital levels, at hospice levels, or home levels? What are the resources available like that?
So Mumbai city has a very good palliative care support system at all the levels. So there are various hospitals wherein you have different palliative care physicians across Mumbai, Navi Mumbai, Thane. You have a good home care teams. You have two hospices, one hospice and one palliative care center. You have paid services, you have free services. So everything is available in Mumbai city. We just name what you want and it will be offered to you. Right
But
from
are this
smallest thing.
just for an interruption in big hospitals like you said Hinduja, it's available. Which other hospitals we have the palliative care department? Do all hospitals have
So
in
department may not
Mumbai?
be
All corporate
necessary.
hospitals?
Department may not be necessary, but yes, availability is there.
Okay.
So for example, right from Tata
Okay.
Hospital to Hinduja Hospital to Kambala Hill Hospital, HCG Hospital, Apex Hospital. So these are the hospitals wherein you have a palliative care consultant attached. You you have various home care groups who see the patient at home levels. You have free home-based care services. You have paid home-based care services across Mumbai. You just Google them and you'll have all the name. Mumbai Palliative
Okay.
Care Network. We do have a directory wherein we provide palliative care contacts across India. So that directory is available on online. In Mumbai city, right? Yeah, what we were discussing earlier, right? From IV stand to all the medical appliances, it's been available either at rental cost as well as free cost. So there are various organizations or sansthas who provide medical appliances even at free or subsidized rate in Mumbai. And there are organizations who provide them at free. So Mumbai is a city wherein you get good uh, home-based care treatment, ICU setup at home also, if you want. Hospital based care, nursing homes are available for intermediate care. You have palliative care centers wherein you can keep the patient for a specific period of time. You have hospice, Chanti Avedna, which is located in Bandra. So the resources availability is not an issue. The main issue here is referrals of the patients. So the resources are more, I think. The references are less. So once we sensitize the healthcare professionals to be very thoughtful about when to refer patients and when not. I think once we increase the referrals, even the team members will increase. From last 14 years, I am running this show in the private sector from 2015 on December onwards. The references is increasing, but still the references are more towards end of life care management and very few are on palliative care side,
Palliative care.
wherein we try to
Yes.
improve quality of life and the patients live with us
Yes.
for months to years. Those group of patients are very less. The most of the group patients, they are referred at a very terminal stage wherein the patients are with us only for 24 hours to a week. That is a huge group. And at that point in time, we are not trying to work on quality of life per se. We are trying to work on quality of dying. And I don't know how much the family members, they they accept this fact, but at least when I receive a call, and you know, there are two types of calls which I receive. One, कि अच्छा हो गया, patient expire हो गया, अभी तो उसको तकलीफ नहीं है. So that
Mm-hmm.
is one of the worst way to die, because that patient was in such a pain, such miserable, and just discharged from ICU and expired at home within 48 hours. And the another type of call is like, yesterday I had dinner with my patient, everything was fine, and how come suddenly in the morning, when I see the patient is no more? But that is a type of a call which I always expect, because that's the, you know, good quality, that wherein the patient was not in that much of pain or miserable life, or patient was with loved ones, enjoyed the meal, last meal, and patient expired. So these are the two different experiences, and I always look for the second type of call. So resources availability in a city of Mumbai is not difficult. References in a city of Mumbai is difficult. Now imagine the scene in different cities which is not as, you know, advanced as Mumbai.
Yeah. So actually, it's rightly said, when we cannot have a Samadhi Maran, if we don't have a Samadhi Jivan. So if somehow से
Exactly.
समाधि जीवन जीते हैं तभी समाधि मरण हो सकता है. It's a very, very important statement here. So this all things have to
Definitely.
come from beginning.
Yes.
Thank you.
Yeah, Dr. Seema, question is for you. What is limitation of life-sustaining treatment? Is it legal in India, and how can it be implemented?
Okay, so I think with taking off from where Sunil and Piggy just said, right? It's extremely important to have conversations about preferences of care that patients want when they are reaching that terminal phase. So invariably, what happens is, we keep these conversations pending till the last minute. We are always looking at cure, and managing the disease. That by default, when as patients are nearing end of life, where do they land up? With you, Gauri, Dr. Gauri, in the ICU, right? You would be seeing in the ICU most of the patients that who get transferred in, like, come during the last stages of their terminal illnesses, isn't it?
Yeah.
And they come to the ICU to die, basically. And which is a we know from the beginning that this is a chronic illness, this is a progressive illness, this patient is unlikely to survive. So in that process, it's important to have discussions about what are their goals and what are their preferences about aggressive medical management. Okay, do they, like my uncle who had an ILD, we had these conversations with him, and it was decided that he would not go onto a ventilator because we knew it's not going to help him. He was 90. He had extensive lung disease. He was dependent on oxygen. Slowly, the requirement of oxygen was increasing. There was no reversibility in the disease, right? So there was no point in putting him into an ICU when he deteriorated or putting him on a ventilator. So we had this documented already. Similarly, a patient with, a patient who's having whether he wants to go in for a dialysis or not, when you anticipate it, these are conversations that you can have with them beforehand about limiting these life sustaining treatment when it is futile, right? About cardiopulmonary resuscitation. Okay, when I was working in the ICU initially in Manipal, they would not resuscitate, but they would document that CPR attempted karke, isn't it? That's a no, because we know
Yeah.
it's not going to help, but we document it in the file. So there is a legal way in which you can do it. You can decide beforehand whether patient wants resuscitation or not, needs ventilatory support or not, even artificial TPN, where in a futile sense, there's no need to start a TPN. We have conversations in patients with oral cancer. Do you want a Ryle's tube inserted? If you reach a point where you cannot eat. So these are all discussions that you can have with patients and their family members about limiting life-sustaining treatment. It could, futile treatments should not be given. Ethically and legally, it's not right to make a patient go through an intervention that is not of benefit to them. So that is what limiting life-sustaining treatment is. It could be either be withholding treatment, or it could be even withdrawal of ventilatory support if it is futile. This is perfectly legal. We have done it in Manipal, and as Rajam said, there is a document called Blue Maple, okay, that gives you step by step on how you go about enforcing it. I think the recent Supreme Court guidelines also have come, and recently, just about 2 days back, ICCM, the critical care medicine, as well as IAPC have together brought out a joint position paper, which also gives details of how it can be done. It's something I think every healthcare provider should read, because it gives you the background and the support on how you can go about implementing this in your hospital. And we have done it in Manipal when I was working there. We have, during COVID, we have had these conversations beforehand on patients who have come with COVID, so that in case they deteriorate, we didn't have to put them on the ventilator. Because these were patients with terminal cancer or some other illnesses where we knew recovery would not be possible. So we've had these discussions with them. It is a doable thing. And how to implement it is to have a good end of life care policy in your hospital. So you can't do it alone. You need your consultants to be with you. If you are in a closed ICU, you can take a call. But if it's an open ICU, you have the primary care team coming in, isn't it? So they also need to be part of the decision-making process. Your administration has to be part of the decision-making process, right? So there is this whole policy you need to create so that all stakeholders are on board, and you then can have a seamless integration of this withholding, withdrawing, life-sustaining treatment into your ICUs.
Pinky, you're on mute.
Pinky, you're on mute.
Sorry, some of the patients who are on end of life care or a palliative care, sometimes they have acute exacerbation of some symptoms, and
Yes.
which are correctable and curable. So we
Absolutely.
had 2-3 incidences where patient had a ischemic bowel disease which was dissected and patient was fine. One was a gallbladder volvulus, all 86, 88-year-old. And the relatives asked us, are you sure you want to operate? So we confidently said, yes, this is the best chance. If not now, you're not going to make it. So we have to have a balance of there also. Like when there are acute symptoms, that should not be ignored in patients who are on palliative care.
Absolutely. Absolutely.
So
I
Next
correcting
question,
Yeah,
to Dr. Rajam.
the reversibles is very important. But suppose what we have seen, you've done the surgery is done well, but something else happens to the patient.
Yes,
At that point, also we should know where to draw the line. That
absolutely.
doesn't happen often. Sometimes a
Hmm.
patient has gone in for a fall, hip fracture, replaced, hip is fine, but the patient is
Patient is not fine.
then you need to see the whole picture and say, this is not working well. Surgery
Correct.
is gone well, but we really need to take a call at 90 now with this. Do you want to go? So that conversation is also important. We need to
Absolutely.
know when to wear the palliative care hat and when not to. That is very important. See, because the biggest fear that doctors have is, am I doing something which is legally right? So the biggest thing we need to know is that whatever we do in palliative care is medically, ethically, and legally balanced, because it has to follow medical ethics. It has to be in the best interest of the patient. We should do what the patient desires, which we never unfortunately asked, what is your choice, what is your opinion? And we need to see, are we doing more harm? And in the pandemic-like situation that Seema spoke about, justice, very important. A 40-year-old should be given that chance to survival vis-a-vis a 90, where we know the world over 90-year-olds did poorly with COVID. So we should balance this whole thing on the basis of medical ethics, and our legal system is supporting us with a lot of documents, which unfortunately we doctors in the medical world do not have the time or the bandwidth to understand. So we focus on, it's better to err on the side of caution. Karte raho, karte raho, karte raho. But that karte raho also has a big price to pay for everybody, including hospitals. See, one of the things that we need to learn with health economics is that keeping a patient in an ICU bed for 1 month is detrimental to an ICU, the corporate hospitals. In Ulta, if you have one bed which has a rapid turnover, make the patient better, go out, another patient comes, it is going to be beneficial economically also. So we need to choose the kind of patients we put in ICU. All people are not ICU candidates. That document also has come out recently in the past month. the people for admission and discharge of ICU. Everybody should not be going through ICU, and especially in a resource crunch country like ours. Also, the staggering statistics of 55 million people going below poverty line because of health-related expenses, unnecessary, aggressive, futile treatments. So we are putting the system, the community into a situation where people turn around and say, we cannot trust doctors. We cannot trust, each one of us talk to at least 10 or 15 relatives every day saying, wo doctor ne mujhe ye bataya hai, ye dawa kiya hai, should I do, should I not? Because the trust and faith in all us is at all time low, and it is only us who can make that difference. So if we show the patients we care about them because we are health care professionals, it is going to make a difference.
So give us some tips how to improve the communication.
That is like learning to cycle and swim. So you need to practice. It is the practice, practice, practice. And like Seema
Yes.
said, Karunashreya has beautiful courses on communications. The more we practice, none of us are born communicators. We learn. And this can not only help in professionally, it helps personally, how talking to your maid, talking to your child, talking to your driver, talking to your staff, all that changes in a manner. If you talk well, if you learn to talk well, life goes easy because you choose the right words, the right tone, the right body language to communicate. So courses are the best way to put yourself. And also please remember, talking when the sea is calm is way better than in a storm. Like swimming, will not go into the sea if it's so. Imagine talking outside the ICU is the worst place to start communication because everybody's para is garam. The relatives don't want to listen. You are agitated. You have 10 more patients to see. It has to be planned. So these things are small things. Even you and me know corridor mein baith ke baat karna. It's not lift mein baat karna patients. It is totally not ideal. But we do
I think
that.
I think the best policy is be a good listener.
Absolutely. But at
So
the same
then it
time,
helps.
the timing. You know this patient is deteriorating, grab them, saying, I want to talk. I'm concerned about your father's health. I would like to talk about this. This is not going the way it should be. Nobody will say it's okay, forget it. I don't have the time. No relative is going to say that. You need to make that time.
So it's like surgery, right? One of the I was reading one of the gynecology papers, they talk about gynecological oncology. They talk about communication, right? It is almost equivalent to surgery. It requires precision. It requires the right time. It requires set of skills that you need, what we call as micro skills. And you said listening, right? Active listening. It's about being empathetic. What are the words that you use? Sab kuch theek ho jayega. Chinta mat karo. That's something that you should never say, right? And it comes automatically to most of us, when
And that is the first thing which has been mostly widely used by almost all healthcare professionals. And that is the first thing which confuses patients relative that सब ठीक हो जाएगा बोलने के बाद अब क्या बोल रहे हो? I mean, then they don't understand what is the difference.
it's
Continue, Seema.
Yeah, so I think and it doesn't come naturally because we are not trained there. Though now undergraduate training have incorporated 8Com training into it, attitude, ethics, and communication. But for us, we never had. Even as a psychiatrist, I never got any training in communication skills. I learned it after I came into palliative care. So I think that's and most 80% of malpractice, violence, that results that we see are the result of inadequate communication. So I think it's about learning how do you handle these situations? What are those skill sets that you need? What are those words and empathetic tone that you need to incorporate? And of course, learn it and practice it. Practice, practice, practice. I guess and there are certain protocols also. How do you break bad news? How do you have goals of care discussions? There are protocols for that, just like we have surgical protocols or and antibiotic stewardship. You also have protocols for this. So learning
Exactly.
about it is extremely important. Yeah. I think we have about
I
some.
think, yeah.
Yeah.
Any question?
There is a
Questions
There is
question
from the
some
about
participants?
self-care. Seema, you're the best person to answer. I have sent some replies, but you are the best person to answer.
What is the question?
About
Self-care.
self-care, how do you keep yourself empathetic always?
Oh, self-care is something I think very essential for all of us. It's about it's as simple as taking care of ourselves. Okay, we have multiple roles, right? Professional role, personal role. There's also some keeping some individual time for yourself. Finding something that you like to do and continue doing it. And also, see, most of the time when you practice ethically, when you do the right things at the right place at the right time, a lot of your distress dissipates. It's when you feel helpless, when you have a patient and you feel helpless that you've not done your best, it creates a lot of distress within you, right? So one is to have the skill sets to do the right thing. The second is to take care of yourself. When you come back home, ensure that you don't carry work back home. Ensure that you devote enough time for activities that you like doing. It could be for family, it could be reading, it could be writing, it could be going to the gym, So this has to be incorporated into your daily routine, the self-care component of it. I think that's how you can sort of cope with high stressful situations.
Gauri, you have to ask something?
Yeah, so one last question. How do you conceptualize good death?
I
All of
think,
you can answer one by one.
yes,
It depends.
you're talking to the panelists or to the people who are listening to us. I think it's very important that each one of us thinks about it, isn't it? What is a good death to me, right? I would look at probably first is knowing that I'm going to die. I need to know because I might have a lot of things that I want to do. I would want to give certain things to certain people, right? Would want to say, reach out to a friend whom I've not spoken in a while and tell how much I miss them, right? So it's about knowing when death is coming. I would want to know. And when I look at a good death, I look at something that is free of physical suffering, right? Probably at home with the bed that I am used to sleeping in, with my favorite pillow by my side, and my family at my side. I mean, that's how I conceptualize. I know whether it is prolonged or whether it's sudden, we have no control over. One aspect of thing that we have control over is who's there with us, where do we die, who's going to be there with us, right? That is something that we can look at.
Dr.
Also,
Rajam?
my mantra is what I've always heard my grandfather say, Anayasena Maranam Vina Dainyena Jeevanam. So it is a very important concept that, we need to die without suffering and live a life which is fully, as much as possible, disease, full potential to enjoy whatever is happiness for me. And that is to each his own. So it's important to have these conversations with patients, see to it that we cannot change the predictability of his illness, but at least let's make the suffering less. Let's not, when we know it's not going to be good, don't offer dialysis. Today also I got a call from a batchmate whose 92-year-old father has had an acute MI with LVF. Lasix has stopped his urine, and the nephrologist said, now the only thing I can do is dialysis. He calls me and says, how can I give my father comfort care? Who will give me morphine? He's in a private hospital. It is so frustrating to not be able to do this. And he's scared to bring his father home because what will happen to him? So we need to realize that we are not here, we are not God. We cannot fight death. We need to let nature take its course and therefore offer dignity. And this whole thing was, I will fight cancer, I will fight the disease. He's a fighter. He will, but everybody has to go one day. And that we need to recognize, and that we need to be able to communicate with the relatives, saying, what is it that your father or mother would have wanted?
Dr.
That's
Sunil, you would.
Yeah,
Sorry,
so
Dr.
this is
Rajam.
all about advanced directives. I mean, you're
Hmm.
talking about including living wills.
Hmm.
So it's a
Hmm.
document which is legally accepted in India also, and we should, if you wish, you can make your own living wills where you can have your preferences for the medical treatments when you are not in a position to express
Yeah.
yourself. So you can make like we make our will, property will, and all those things. So similarly, you should make your living wills. So that will give a clear understanding to the healthcare professional to what extent you can go for the treatment part. And about dying, so dying is a very personal thing. Everyone has their own way of looking at that.
Yeah.
The first thing is start conversation. हमारे इसमें अभी भी we don't talk about dying. Dying is the inevitable thing. I mean, when you are born, that moment only you started dying because your time has started. You're going towards your death. This journey, how comfortable you can be in this journey and who all you want to be in this journey, that is important. So dying is inevitable. जैसे born हुआ है वैसे death तो होना ही है. ये बीच का part में you have to see how you want to go ahead. So yes, if you're talking about legal papers, living wills, advance directives, if you're talking about dying peacefully and in a dignified way, everyone have their own choices once they understand that they have a serious illness and to what extent interventions are possible. Understand those interventions. There are patients who want to live with tracheostomy tube. There are patients who do not want to live even with a RICE tube. So every individual choices have to be honored. So that's what we talk about autonomy, beneficence. So these are the principles of palliative care. So yes, dying has to be spoken about. Conversation is the first step. And then when you understand your treatment journey and the interventions related to the same, then they will only tell you what to what extent you can go ahead. I think conversation is the must there.
So there's one interesting talk. I mean, I know you're running out of time about legal aspects. I think there's a Dr. Reena who is asked, and it's a very important topic, but I didn't understand her question. If you have time, I mean, I'm not forcing you to take up that question, but please go ahead and check.
I don't
Yeah.
know.
She's
What
mentioned that
legal
legal
aspect?
aspects on patients suffering from prolonged illnesses and
About
wishing death.
death.
Wishing
That's
death.
that's
She's talking about euthanasia.
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 That's
Yes,
not
yes.
what we want. You in a
No, no,
country.
Mhm.
no.
1 minute. In a country which
Nobody is
does
saying
not
here.
have
Yeah, go ahead,
robust,
Rajam ji.
in a country which does not have robust palliative care, thinking about ending life is not acceptable. Why do people want to end life? Because they are suffering. They're suffering pain, they're suffering social aspects, they're suffering financially, they're suffering, the family is suffering, everybody's suffering. When those sufferings get addressed, very few people want to really end life. Then so therefore we need to talk on health related suffering, a holistic approach, think about psychosocial, especially in a country like where there isn't and world over, hardly people are getting palliative care. To me, as a doctor, as a human, talking about death is not acceptable. So ending life voluntarily is not the talk here. Pushing death, hastening death is also not the only it is so focusing on controlling the symptoms, making the human being feel better about himself in the given circumstances, support him, handhold him so that the journey is bearable and be his friend, mentor, etc. with the help of the layers of palliative care that we can offer.
Actually, it's a simple story. When we go from one city to other city, we take a flight. When we get down from the flight, we never say, I'm missing my flight or I've left my flight. We don't cry. Similarly, when we leave one body to other body, there is no need to cry. It is just a transition. So that concept has to come, that spiritual concept has to come in all of us when we are caregivers also, to make the patient realize it's just a transition from one body to other, and a healthy transparent discussion, as Dr. Seema said, has to come from beforehand. The moment you are, it's not giving up, but it's accepting and graciously accepting, so that you're ready for a new body, a new life, new relatives. You're ready for everything. And it's, believe me, it's smooth and transparent. It's very, very happy ending then for everyone. The whole
Our
atmosphere
problem
is
is the
peaceful.
medical curriculum training is much to be desired. The problem
Yes,
is
spiritual
ingrained in
has
us.
to be ingrained.
So it's ingrained in us of that we cure lives, we save human lives. We keep only cure, cure, cure. Even during residency, we used to say, "Mere duty pe nahi marna chahiye patient." The whole concept of this fighting over death, overcoming death, that the whole concept of the way we look at death is different. So I think that needs to change. We need to get more comfortable about talking of death and dying. We need to talk to patients, first of all.
Even I felt end of life word also is not a correct word. I felt it's like beginning of a new life. So why end of life? Nothing is ending, and there is no fighting with anyone. It's just accepting graciously. But I think that
Yeah.
has to percolate, individually. So thank you, everyone. And there's one more question, last question. If patient is conscious, unconscious, and relatives are in dilemma, then what to do? So that
Exactly.
again,
Living will.
yeah,
No,
living
so
will.
that is if the patient's living
Patient is
not
unconscious.
So there are 2, 3 things to tackle it. Seema, you can add if I'm wrong. One is they know the patients better than you and me. So you ask them, what would your father have wanted? Because you know them better than me. 2 is you explain medically and say that, this much chance of futility, this much chance of life survival, this much chance of, let them decide. The third thing is if they're not able to decide, then you do everything.
The fourth point is then give a trial.
Yeah, exactly.
Let us, okay, we are also not sure what is going on. Family is also not sure. So we give a time frame. Okay, let us see if the patient, we will do everything that we can. We'll see if the patient, there is some response or not. If there is a response, then we go ahead that path. If there is no response after 48 to 72 hours, then probably we cease. So recently I had a patient who similarly advanced metastatic vulval carcinoma. She became delirious. I suspected sepsis. So the one option what I gave was we start piptaz and amikacin.
Higher antibiotic.
Yeah, higher antibiotics IV. We give it for 48 to 72 hours, see the response. If she responds, fine. If she doesn't respond, we don't escalate into meropenem or colistin, right? So give a trial and see, right? My only problem was, suppose the doctor was not able to find an IV, would I go in for a central line? I was praying that I didn't have to take that decision and we didn't have to go there. But she sort of recovered with the IV antibiotics. So, but it's just a recovery clinical, I mean, the symptomatically. Her blood parameters, CRP still are off the roof. So we bought some time. So some part of it may be reversible, right? So that giving a trial is also the fourth way once if you have neither of that, if you're not sure about what you're doing.
There's one more question. What's the expected life should be considered for fracture surgery according to palliative care experts, especially hip fractures?
It depends on a
Oh,
lot
I don't
of
know.
things. On the
Yeah.
age, you can have 60-year-old who are bedridden,
Hmm.
20-year-old who is independent. So it depends on age, comorbidities, quality of life, what that patient wants. And so if it is a complicated surgery, obviously you need to discuss all that. It cannot be discussed on a broad range and general. It has to be individual, and what that person needs to do post that hip surgery. But most
And
times, elderly people, the fall is the beginning of the end.
Hmm.
You should
metastatic lesions,
you should
bone metastasis.
you should do the hip surgery for pain, etc. But then you also need to explain that if things start failing, the liver, the lung, the heart, then you need to know, like I said, where to draw a line. I'm not saying let the human being suffer in hip fracture pain. That is not what I'm saying. But at the same time, you need to weigh benefits risk and be very clear to the relatives that if this doesn't go or if it begins to go south, we should know where to take a call.
And
So,
on,
like all things, yeah.
yeah,
Gauri, you want to say something?
No,
And
see,
Dr. Seema.
it's also important that we are talking in the context of a terminal illness, no?
yeah.
Life-limiting illness. So very
Critically ill.
highly
For example, a
functional.
90-year-old has fallen and broken a hip,
Yeah.
and then you want to fix the hip, but then something can start going south. It may not go south, but that's the whole thing, right? And it's not the duration of time, Dr. Om Parshuram Patil. Any amount, if I live 1 hour, 1 day, 1 week, 1 month, I want to live in peace and dignity. So it's not that, it's irrespective. I need to be in comfort, correct? That is very important. It's life expectancy is the next thing. That is quantity of life. I want quality, irrespective of time duration.
Hmm. So I think one important thing is timely referral to the right specialty is very important message in this session, which we all have learned. And rather than saying ki we cannot do anything, let's refer them in a timely fashion to the specialist. So like all things come to end, this session also will have to end now. But most important thing is disease, whatever we are talking about, painful diseases are of the body, but ignorance is the biggest disease. So let's be, less ignorant and have a better life in future for ourselves and for our patients. So thank you each one of you for an excellent session, excellent inputs, and we all will incorporate. And of course, I think this session can continue, go on and on. So we might have a part 2 of this session.
Definitely.
Thank you for having us.
Thank you.
And it's really nice what you're doing. Very, very important and needed. So thank you all for this, idea and for the fact of sitting on a Friday night and doing all this after a busy week.
That's fine.
Appreciate
This is
your
our passion.
yeah, appreciate
Thank
that.
you. Thank
So
you.
take away home three points.
Takeaway message, yes.
Yes. Number one, life is a balance between holding on and letting go. Okay. So we have to be brave enough to start a conversation that matters. And we may not be able to change the outcome. Most of the times, there are situations wherein we are not in a position to change the outcome, but definitely we can play a vital role in their journey of life. And it's a team work. And palliative care specialist is a part of your own team. Okay. See you.
Dr. Sushma wanted to talk. How do we unmute her? Yeah. Dr. Sushma from Nasik.
So that I thank you Umang team, and I'm from Nasik test physician. I have one एक मेरा पेशेंट था और उम्र ज्यादा थी, इन सबड्यूरल हेमाटोमा हुआ और fever, and he was operated for the subdural hematoma, but afterwards I become unconscious, and maybe the TBM that finding. Then we have treated them, but he was unconscious for 1.5 months. And we colleagues are not ready what to do in that line. Hence, I asked that question. Ki, if there is some individual variations, and what to do at the last moment, and how to communicate them and how to tell them. They are RT feeding also, they are not ready. Is it not possible? Then we have convinced them, but it is very difficult to.
So I didn't understand the gist. It's difficult to convince them for RT or against RT. I have not understood the question. Seema, maybe.
In fact, I would advise that this should go in a personal call. So you can call any one of the palliative care specialists, give more detailed background. We will have certain more questions to ask. And based upon that, you can frame up the outwork of that conversation. So in a common forum like this, I think should be avoidable, whatever the other people see.
Pinky, you are happy to share the numbers of either of us so that we can help that
Yes.
the lady.
Yeah. Yeah.
Okay, sure. Thank you. Thank you so much.
Thank you.
Thank you all
Good
participants
night.
also
Have
who
a
have
good
been there.
weekend.
Good
Good night.
night.
Good
Have a
night.
happy weekend.